So hi everybody, I'm really happy to be here. And I'll be presenting just a few results from my study on process and outcome in short-term psychodynamic psychotherapy. Attachment is not our main research question, but it's becoming more and more important as we discover how relevant it is. So I called the presentation Different Strokes for Different Folks, meaning attachment plays a part even in short-term psychodynamic psychotherapy. Okay, so first of all, since this is psychotherapy, my interest is how does attachment affect exploration? And exploration is psychotherapy, exploring yourself, exploring the relationship. So John Bowlby posited that individuals form, this is just like a brief recap, form internal working models of self and others in close relationships based on their experience with childhood caregivers. And these models broadly represent secure or insecure attachment. So regarding exploration and secure attachment, parents or caregivers meet the child's needs for safety and security, and they're able to regulate the child's emotional experience. In insecure attachment of the different types, they're formed when parents do not meet the child's needs for safety, do not provide the appropriate emotion regulation. So we know from Bowlby that attachment system interacts with the exploratory system. So exploration is activated when attachment needs are met. Someone is behind you, helping you, so you can explore, and cannot really be activated successfully when the child doesn't feel secure. So with secure attachment, fosters exploration and autonomy. Insecure attachment reduces exploration and autonomy. Autonomy results in difficulties regulating affect. So if this happens in childhood, we're going to take this into psychotherapy. And there has been literature and studies on attachment in psychotherapy in different ways. So first of all, even John Bowlby wrote that the therapeutic relationship is likely to reactivate the client's longstanding expectations about the availability and responsiveness of others. And since I hadn't read Bowlby for a long time when I was teaching it, I was kind of pleasantly surprised to see one of his chapters, how he talks about recognizing whether the client is avoidant or anxiously attached or securely attached, and how to really form the alliance and start working with them. So there have been many studies that secure attachment predicts a positive working alliance, facilitates the emotional exploration in therapy in different modalities and engagement. A meta-analysis by Ken Levy et al. Showed that patients with secure attachment pre-treatment had better psychotherapy outcome than insecurely attached patients. And of course, greater improvement in attachment throughout therapy predicted greater improvement in outcome. Hadass Wiseman and myself in one of our studies, psychotherapy studies, we found that patient-therapist match on low avoidant attachment was related to greater symptom decrease. So there's something going on there. So our thoughts in the current project I'm doing was that attachment could be a possible moderator in psychotherapy. Now, why were we thinking of moderators? So first of all, there is a current focus in the field, both in the clinical field and in the research field, on personalization of psychotherapy. So we have our evidence-based models, but apparently there's still dropouts, and in an evidence-based model, you want to adapt the model to the person. So attachment would be one variable that could be interesting, because we're challenged to find personality traits that may impact our patients' experience and how they work. Also, another term that's kind of appears a lot in the research literature, but it's actually a very clinical term by Bill Stiles, is the concept of responsiveness. Being responsive to your patient's needs, not just in general, but in the emerging context, in the moment-to-moment therapy session. What's going on? What does my client need now? So possibly one of those needs would be an attachment need. Thinking of an avoidant person when I'm too close or too distant. Sharon Egozi has published about that. Okay, Steele et al., apologies for the typo, I apologize, the dropped E. So suggested, and I learned from that paper, using the adult attachment interview to study process and outcome in psychotherapy, since the AAI is rated both on attachment and on reflective functioning. And you pointed out that patients in psychotherapy may actually shift from insecure to secure states of mind in the course of therapy, in the relationship with the therapist or in general. And each state of mind may require particular therapeutic strategies. So it's kind of important to look at that. Mikulincer and Shaver also had a big study that reviewed several projects that showed individual differences in attachment are actually reflected in various patterns of emotion regulation. So avoidant people are more likely to cope with threatening events by relying on cognitive distancing. They become more intellectual. Emotionally disengaged, anxiously attached people tend to engage more in rumination, being attentive to distress, eliciting stimuli. Jean Watson et al., I think in a study of EFT, found that anxiously attached patients benefited more from experiencing their therapist as empathic than patients who were more securely attached or avoidant at the beginning of therapy. And I found this finding particularly interesting because empathy is important for everyone. It's like a basic common factor in psychotherapy. But the idea that anxiously attached patients benefit more, okay? So I thought that was kind of important. And in the same study by Levy et al., they suggested that patients with pretreatment attachment security not only do better in therapy, but do better in specific kinds of therapy. So it also becomes interesting that they do well in a therapy that incorporates a focus on interpersonal interactions and close relationship. And I'm thinking, Miriam, of the talk you just gave, they have better reflective functioning capacities, and so they can benefit more from a therapy that is actually more reflective. So in a study that I do with a group of doctoral students on process and outcome in short-term psychodynamic therapy, we, among other questions, we examined the role of attachment in the process of rupture and repair, which is something I'm interested in, and I'll provide the definition in a minute, rupture and repair in the alliance, and in relation to changes in emotion regulation. So I'll present just a few results from these studies. And this picture is taken from Chris Moran, one of his doctoral students, showing a confrontation rupture. Okay. So the first bit was one of in the larger study. It's a study that my doctoral student, Maayan Levy-Chaimovich, is leading and has presented in one of the SPR conferences, attachment styles and the rupture resolution process. So just very briefly, for those of you who are less familiar, ruptures in the alliance are inevitable moments of tension or breakdown in collaboration with a therapist. They vary in intensity and length of time. They're created by both. Now, rupture sounds like a really extreme word. It could be like a momentary tension where the therapist is saying something and the patient doesn't get it, or the other way around, or it can be tension that may last the entire session or even more. So working collaboratively on ruptures and their repair, which today is also considered sort of a common factor already, focuses on exploring the interaction in the room. So when there is a rupture, when there is tension, something is stuck, or there is a pause, or productive work is not really going on, usually the therapist has to kind of recognize the rupture, decide what they want to do with it. There are different interventions, but the point is to get the session back on track by either inviting the patient to look at what's going on, to talk about their feelings, or explaining what's going on. So I was thinking that, building on all the previous research I was reading, that the work on ruptures may really be different for patients who are more securely attached and less securely attached because it focuses on the relationship in the room. And not many studies have examined the relationship between repairing ruptures and patients' attachment style. I found a few, and maybe there are a couple of new ones that I should check them out. So Eames and Roth in 2000 showed, and this was a series of case studies, that preoccupied attachment style was associated with more ruptures, whereas the dismissive attachment style was associated with less ruptures because they interact less. Okay, and actually, maybe I forgot to say, the occurrence of ruptures is an inevitable process, like with every two people, friends, romantic couples. There are always little misunderstandings. There's always someone maybe being a little hurt or taking over. So this always happens. We don't want to prevent or avoid ruptures. We can't. The point is how to use them in a creative and productive way, not just to restore the alliance, but to learn something from what happened just now in the room. So Miller-Bottom et al., also in a series of case studies, showed that secure patients disclosed their present experience openly. Again, I'm thinking now that it's related with better reflective functioning. So when they were invited to talk about, okay, what's going on here? We're stuck or we seem to be in a power struggle, they were able to discuss and focus on what's happening in the here and now. And insecure patients were much less able to do that. They either minimize their contribution to the dialogue, or they don't understand what's going on, or they're distancing. And they also minimized, the preoccupied ones minimized the contribution of the therapist, of course. They wouldn't say something like, you don't understand, or I didn't like the way you went. They would kind of distance. Sigal Zilkamano in her Haifa research lab found that patients with major depressive disorder, again, with higher levels of attachment anxiety, showed greater treatment efficacy following supportive expressive therapy, and I'll explain a little bit because both of us are doing the same therapy, that they did better in a therapy that also provided expressive interventions, which are the deeper interventions that also focus on transference and defense mechanisms with supportive interventions. And so they did better in this combined treatment than a therapy that applied only supportive interventions. So that's kind of interesting to think about all those things, but we see the differences in the way they work and experience. So this is like one little hypothesis from a lot of others in the study. And we focused mainly on the anxious attachment style. First of all, our sample is a sample of patients that has to fill the criteria for short-term psychodynamic psychotherapy. So if you're really high on avoidance, you don't meet the criteria. So they were basically rated higher on anxiety than on avoidance, even though, I'll show you later on, we did find relationship with other variables and avoidance. So we're thinking that attachment style would moderate the relationship between therapists' different use of resolution, repair strategies, I'll explain that in a minute, and patients' experience of the therapist as attuned. So for this sub-study, we had 35 patients. The entire study is for patients diagnosed with mild or moderate depression. They're mostly moderately depressed, though not suicidal. Some of them have comorbid anxiety. We had 28 women and 7 men. And we're doing Luborsky's supportive expressive psychotherapy, the CCRT model. For those of you who are not familiar, it's a 16-session therapy where the dynamic focus is a relationship pattern. Something you want from the other person. I need to be loved. I need to be close. The perception of the other. I feel others are critical and don't like me. And the response of the self. This makes me depressed, okay? And there is a way to arrive at this psychodynamic focus. I won't get into that right now. And we had mainly graduate students and interns in their third or fourth year of internship. Okay. Okay, just quickly about the measure, how we measure ruptures and why we only had 35. This is a very labor-intensive process, but it's extremely interesting, and it's one of those coding systems where you code, but you also learn a lot. So we're using the previous version of the rupture resolution rating system developed by Catherine Eubanks, Chris Moran, and Jeremy Safran, and it's an observer-based rating system for coding videotapes of psychotherapy sessions. So there is one way to look at ruptures is by self-report questionnaires, but we were looking at the video coding, and there are all sorts of rupture markers. When would you code a rupture? It could be something minimal, it can be something more lengthy. And also you code resolution strategies. Now, it doesn't mean that the therapist was thinking about resolution strategies. The CCRT model is a short-term dynamic model. You do focus on the relationship between patient and therapist and how it relates to the focus, but it doesn't have ruptures because it was developed a long time before. So we were looking at how therapists intuitively used all sorts of interventions, and most of them are really part of the rupture resolution protocol. Consulting with Catherine Eubanks which sessions to code, she said, try coding sessions from one phase. Don't go all over the place because we're not sure if ruptures are the same ruptures and the process is the same process if you look at session 3 and you look at session 16. So now we're coding later sessions as well. So this is the beginning of treatment. Sessions 3, 4, and 5, which are part of the initial phase of the CCRT. We had a group of trained raters. And the way you code the resolution strategies is you code how successful was each resolution strategy, if it was used at all, how successful was it in resolving the ruptures. So these 4 resolution strategies that I'm presenting, I didn't just choose them randomly. They were the ones who were used most successfully from the point of view of the raters. So the first strategy is called link patient therapist. It's an intervention where the therapist links the rupture to an interpersonal pattern that has occurred in the previous sessions, okay? Especially if you get to session 4 or 5, you can say something like, you know, gee, this happened a couple of times when I asked you to, you know, just say whatever is on your mind and you kind of went blank. Or this happened a few times when I misunderstood you and it looks like it's happening again. So that's the link patient therapist. Invite is what it sounds, inviting the patient to talk. You know, gee, we've been quiet, or we're not getting anywhere, or I sense there is a power struggle. Do you feel the same, or what's happening to you now? So actually inviting the patient to discuss thoughts or feelings that are related to this rupture. Illustrate is a more didactic intervention. The patient will say, especially at the beginning of therapy, I don't understand why we need this CCRT focus. Why is that important? Why is that relevant? You know, that's been explained, but it's like a moment maybe when the therapist is trying to explore something. And so illustrate is basically giving the rationale, a very supportive technique. Okay, I explained it, I'll explain it again. I understand it may not seem relevant. This is why we're doing it. And disclosure is what it sounds, self-disclosure. The therapist discloses his or her internal experience of the current interaction. Okay, and at the beginning of therapy, it was actually used not a lot, but quite often, not very deep disclosures, but something like, I'm feeling a little stuck, or, you know, you're kind of quiet, and I'm not really sure if you need time to reflect, or something is happening here between us, and I thought I would ask you. running quickly because I said we would link these interventions to patients' experience of attunement and responsiveness. I mentioned the responsiveness concept before. So this is a really nice questionnaire by John Snyder and George Silberschatz. The patient's experience of attunement and responsiveness. We handed out, they fill it on Qualtrics after every session. How they experienced the therapy and the session. Was the therapist empathic? Was the session helpful? Did they feel like the therapist was kind of attuned and with them? And the therapists filled the same questionnaires, but how they think the patient has experienced them. So it's not, it is their own experience, but they're supposed to respond to how do you think your patient felt about this session? And like I said, there's so many attachment measures. I'm aware of that. And the ECR, I think doesn't have a really high correlation with the AAI, right? But this is what we're using since we're checking so many variables. We have the 36 item of the ECR, and it's administered to patients at the beginning of treatment. We actually also have the therapists fill it, but that's another study, like an attachment match. Okay, so I'll just show you a few graphs, and then the next two studies, there won't be any graphs, of predicting the patient's experience of attunement and responsiveness on sessions 3, 4, and 5, the sort of beginning of therapy, and the association of the patient's experience with the raters rating of successful resolution using different techniques, moderated by attachment anxiety. And you see the patient's ratings of the pair and the therapist's rating of the pair and how attachment plays out in the way each of them perceives what happened. Now, of course, the patients are not asked about resolution strategies. They're asked about the session. So the pair is influenced by many variables, but we found some really nice results with the resolution strategy. So first we saw that, this is the patient, higher scores on attachment anxiety. The dark blue line is the one standard deviation above the sample mean. So these are the patients who are more anxiously attached. So with those patients, they experienced the therapist as more attuned when there was more use of the linking of the rupture to our relationship. Not in a blaming way, but in a kind of curious way. Gee, this isn't the first time this has happened to us, okay? So patients who were rated higher on anxious attachment on the ECR, when this was the resolution strategy used successfully, they experienced the therapist as much more empathic. Now, if you look at the therapist graph, it's the totally opposite. They actually experienced patients with low attachment anxiety as the one benefiting from this kind of intervention. So you see very different perspectives on the same relationship. Okay. Yeah. So the next resolution strategy is inviting, like I said, inviting the patient to talk about what's going on. And again, you can see that patients who were rated themselves high on the ECR with high anxious attachment actually felt the therapist was empathic, and this was a good session when the therapist addressed them directly and invited them to talk. And if you think of anxiously attached patients, so the therapist is inviting, I want to hear what you have to think about it, so they're not kind of up in the air. And with therapists' experience of, or how they thought the patients experienced the session, attachment anxiety didn't moderate, okay? So it didn't stand out as something specific. Again, you see a difference, how the therapist viewed the session and how, okay. Now here we also have an interesting finding, illustrate, it's a sort of psychoeducational intervention. wasn't used a lot, but often it really resolved ruptures when the therapist kind of explained, oh, this is why I'm quiet now, or this is why I'm using the CCRT focus. So it wasn't related at all to patients' experience of the therapist as empathic, even without attachment as a moderator. Patients didn't experience that as something too terrific. And actually therapists did, they actually thought that patients who were rated as low anxiety appreciated or felt that the therapist was more empathic. So they actually didn't think that patients with high anxiety really benefited. So again, you see very different understandings. Self-disclosure. Interestingly, when I looked at the entire sample, again, it's a small sample, 35, self-disclosure was very significant across the entire sample, with patients feeling that the therapist was really empathic and attuned when they self-disclosed. Again, the disclosure was just on the process, but it had nothing to do with attachment. So everyone liked it and benefited from it. Okay. So some of my conclusions are that attachment anxiety did moderate the relationship between type of resolution strategy and experiencing the therapist as attuned and responsiveness. So patients with higher or lower attachment anxiety may benefit from different strategies and may experience the process differently. And also the fact that there were differences between therapists and patients. I mean, we know we don't always perceive the session the same way. That's why we talk about it. But it was interesting to see the differences, okay? Okay, two shorter presentations of results from the same study, the same therapy. Also with Maayan, my doctoral student. She looked at rupture resolution and changes in the use of emotion regulation strategies. So it's not the use of emotion regulation in the session. We're just doing that now with skin conductance, so we don't have results on that yet. But this was basically looking at using different emotion regulation strategies in everyday life and if that's changing in the course of therapy. So we were wondering, that was actually one of my thoughts, that working on rupture resolution is not just getting the alliance back on track or learning about yourself from the rupture, which is, you know, something very productive for patients, but that it's also some kind of emotion regulation strategy. Again, going back to Bowlby and attachment, if we do a good resolution of the rupture, then it secures, you know, it's a kind of secure experience, and it helps you regulate your emotion. So we were wondering if we can show that. So we have 4 resolution strategies. We have the validate, which we didn't have in the previous one. This is just because of missing data. And we used Gross and John emotion regulation questionnaire that measures patients' use of cognitive reappraisal and expressive suppression. Cognitive reappraisal is being able to kind of shift and view a situation in a much broader perspective, which regulates your emotion because now you kind of understand what happened, whereas expressive suppression is basically kind of stifling your emotions. And I was thinking that successful rupture resolution would really help reappraisal. And we're looking at results. And here, even though most of our patients didn't rate high on the avoidance subscale, there were enough avoidant to, provide interesting results. So this is like without the graphs, just to go through it quickly. So for patients with high and average avoidant attachment style, therapists' use of disclosure as a resolution strategy was associated in an increase in the use of expressive suppression in this initial phase of therapy. So using disclosure a lot doesn't or may not really help people who are avoidantly attached, kind of, decrease suppression in their everyday life, whether it's in the session or out of the session. the question was like a general question, in the last week, and you have all those items. So probably disclosure at this early phase is maybe threatening or coming too close or doesn't really help. Also, interesting finding, those same patients with high avoidant attachment, when therapists use the link patient therapist, remember linking this to, gee, this is happening again, or it's not the first time you felt that I didn't understand, so let's see what's going on. So this was actually used with, this was actually correlated with decrease in the use of expressive suppression. So at first we were a little surprised, and then we kind of thought, we viewed the tapes and saw how therapists, did these interpretations. And since it's the beginning of therapy, they were kind of more leaning towards a cognitive style. Okay, this is not the first time, we'll understand what happens here. And we're thinking maybe for high avoidant patients, this sounded kind of like an interpersonal explanation. Wasn't too deep, maybe not too threatening. And with low avoidant attachment patients, we found the opposite results. Higher use of linking patient and therapist patterns was associated with their increase in the use of expressive suppression strategy. I don't have an explanation for that. I have thoughts. I'd be happy to hear your thoughts as well. Patients with low anxious attachment style, we found higher successful use of the link patient therapist intervention, also associated with an increase in their use of expressive suppression. So for people who are low on attachment, low on avoidance, since they're two separate scales, but they might be more securely attached, the linking of patient therapists didn't really affect their use of everyday reappraisal. So they're probably capable of much more exploration, and just pointing out a repetition of a pattern in itself didn't lead to an increase in the use of reappraisal. I'll read the next one. Patients with high anxiety style. And here is another resolution strategy that's called link relationship. So this is not looking at the rupture and saying this is happening to us again, but has this happened to you in other relationships? So, so they really have to kind of explore and think about their life. And people with, patients with high anxious attachment, using this kind of resolution strategy was associated with a decrease in their use of cognitive reappraisal. You would, because maybe high anxiety, and you're supposed to think of, gee, we kind of got stuck here. Does this happen to you with other people as well? So at this stage in treatment, that may not really foster reappraisal. They may kind of want to shrink back. And finally, the last piece, which is conducted by my doctoral student, Gershon Gwirtzman, who is now in Gaza for the third time after he's already done 300 days of reserve duty. But he worked a lot in between, and it was amazing the shifts he could do in between army service and war and getting his proposal and doing research. So he's looking at difficulties in emotion regulation. I'll show the scale in terms of what does therapy help us achieve in terms of difficulties, what am I improving in, and is there a difference for people with different attachment style? So this is a somewhat larger sample from our sample of 100 patients. 63 patients, male, female, diagnosed with moderate depression, the same sample. We had 46 therapists, so a few therapists had maybe 2 clients rather than just 1, the same CCRT treatment. Our measures in terms of outcome, we use the outcome questionnaire, Lambert's. It has a Hebrew version that's been validated, reliable and validated, and we're using, again, the ECR. And just a few words about the difficulty in emotion regulation scale. It's in, this is the short version, the 18 item, not the 36. It's a self-report questionnaire, again. that evaluates patients' challenges in regulating emotions across 6 dimensions. So it's a very complex kind of scale that looks at different things, looks at awareness of emotions, clarity, how clear are your emotions, can you really identify what it is you're feeling? Awareness is, are you aware that you're feeling right now? Non-acceptance of negative emotions, feeling bad about being angry. Use of regulation strategies, any regulation strategies, working towards goal, and how impulsive you are. And respondents, again, this is session by session, rate how often each item is applied to them, Okay, and the data analysis, of course, is HLM, and just a few results. Am I doing okay on time? Okay, 5 minutes, I'm fine. I have 3 more slides. Thanks. So just the main results. First of all, across the entire sample, and this was important, there was no significant change in the total DERS score and no interaction with attachment scores. And of course, at first you're disappointed, and then I'm thinking to change in so many issues in 16 sessions doesn't really make sense, but are there slight changes, and would they be different with people who are more anxiously attached or avoidant? So the interesting finding that Gershom found was a significant interaction effect of time and avoidant attachment style on difficulties in the emotional clarity, which means that patients with a higher score on the avoidance scale improved in clarity, okay? So what happened to them across 16 sessions is they were able to start identifying their emotions in a more clearer way and kind of use that. And they also, so there was a significant decrease. Then people who were more anxiously attached, there was a totally different change. The change for them was the improvement in acceptance of negative emotions. So they were more able to accept negative emotions. And they're very clear items like, can you accept the fact that you're sometimes angry or mad, or how do you feel? And of course, a lot of this is discussed in the CCRT treatment. We discuss emotions, we talk about emotions, but the fact that they changed on different subscales we thought were interesting. And the last finding that I'm presenting here is that patients with higher avoidance style, although they improved on clarity, they really became a little bit worse on the use of resolution strategies, different types. And we were thinking, okay, this treatment is kind of very emotional. It's not just cognitive, and maybe it's a little too much, and a lot is happening, but they're still not getting the regulation, and we didn't help them with that. We were thinking that individuals with avoidant attachment style tend to suppress their emotions, so participating in short-term psychodynamic therapy may be correlated with increased emotional clarity, so that was a contribution. And again, they weren't very high on avoidance, otherwise they wouldn't fit the criteria for short-term psychodynamic therapy. And just jumping to the last point, for patients with anxious attachment, or findings may reflect increased emotional acceptance, which might help these individuals contain their emotions rather than externalize them to elicit support from others. And our summary, attachment style may be one of those personality traits which guides personalization of therapy, remember. Of course, we need a lot of research, how to adapt therapy models to patients with different attachment style. So Steels and Steel book discusses that. Therapy process itself and the kind of change may differ between patients with different attachment style. So Sharon Egozi, who is here from Tel Chai, actually found that experiences of closeness and difference were very different for patients with attachment avoidant or anxious. And a very recent study with Celia Jacobson and a group of other European researchers actually shows that. And what I didn't discuss, and I'm ending, and sorry again for the typo, my anxiety, I think that We have tested, I haven't presented Rivka Shear's doctoral dissertation, from which he already published 2 papers, looks at therapist attachment style and the match, and thank you.